Hello everyone, myself Dr. Ashwini Kumar. I am faculty of Human Anatomy in Dr. Bhatia Medical Institute. This is a small demonstration lecture to tell you about the difference between the traditional system of teaching that we undergo during our academic years in MBBS and how we do these things to make it more simple and more agile. So I am going to take a small topic here and not take much time of yours, and we will try to condense that topic in a smaller format, so that you can see that how a longer thing can be converted into a smaller topic and still we can extract all the necessary informations out of it. And as we know, our target is to solve all those MCQs which are asked in the exam. So the topic should be done in such a way that the topic is reduced, the workload is way less, and we should also be able to do every single question which is important and could be asked from that particular topic here. So I'm going to take one example here. I'll take an example about the thenar muscles first, and I'll discuss one nerve with you which will take around 15 minutes only. So guys, as we all know that the hand is having the set of muscle called as thenar muscles. The thenar muscles, which are the muscles for the thumb, and we have these four thenar muscles called as flexor pollicis brevis. We got abductor pollicis brevis. There is a muscle called as opponens pollicis and adductor pollicis. Now we usually don't like this topic in first year when we read anatomy, the hand and foot. There are so many muscles present inside. So let me try to extract that important information out of it, and so that we can do the questions related to them. Guys, look at this. The muscle is called as flexor pollicis brevis. The word is brevis here. Abductor pollicis brevis, but there is no brevis or longus which is in front of opponens pollicis or adductor pollicis. When you say flexor pollicis brevis, that means there is one more muscle called as flexor pollicis longus, and that muscle is coming from the forearm. And when you say abductor pollicis brevis, again it means there is another muscle called as abductor pollicis longus coming from the forearm. So for that particular movement we actually have two muscles. So we get two muscles for the flexion of the thumb, and we got two muscles for the abduction of thumb. But the unique thing is that there is only one opponens pollicis and there is only one adductor pollicis. That means there is only one muscle for the opposition movement of the thumb, and there is only one muscle for the adduction movement of the thumb. Now why this information is so important? As I said, we probably didn't pay much attention to this thing when we read all this in first year. If you look at these three muscles here, they are supplied by median nerve. And adductor pollicis is the only muscle in the thenar compartment which is supplied by ulnar nerve. How is that important? Median nerve supplies flexor pollicis brevis, it supplies abductor pollicis brevis, it supplies opponens pollicis. Now, if let's say there is injury of median nerve, so there is injury to all these muscles, but if the median nerve is compressed at carpal tunnel, now understand this, if a median nerve is compressed at carpal tunnel, that means these three muscles are involved. Flexor pollicis brevis is gone, but we still have a muscle called as flexor pollicis longus. Abductor pollicis brevis muscle is gone, but we still have a muscle called as abductor pollicis longus. But opponens pollicis is the unique muscle. There is only one muscle for opposition, and that is gone when there is injury to median nerve. So if the question says that which muscle is completely or lost, or which function of the thumb is completely lost in median nerve injury at carpal tunnel, that has to be which one? That has to be the opposition, because opponens pollicis is the only muscle and it is supplied by median nerve. So guys, injury to median nerve, there is loss of opposition. There is loss of opposition of thumb. Now this was the question once asked in the exam, that if there is a median nerve injury at the level of carpal tunnel, which function of thumb is lost? That is median nerve. And they also asked this question once, that which function of thumb is completely lost in ulnar nerve injury. Now that's very simple, because ulnar nerve is supplying only one muscle in the thumb, and that is adductor pollicis. So guys, if there is ulnar nerve injury anywhere, doesn't matter the injury is in axilla or arm or forearm or at the wrist, but if the ulnar nerve is involved, that means which muscle is gone? Adductor pollicis. So in case of ulnar nerve injury, In case of ulnar nerve injury, the one function of thumb which is lost is adduction. A function of thumb lost in median nerve injury, opposition. Function of thumb lost in ulnar nerve injury, that is adduction. And we know all the extensors are supplied by radial nerve. So if there is injury to radial nerve, there is loss of what movement? That is extension. So in case of radial nerve injury, there is loss of extension. And we are talking about thumb, guys. I mean, extension of the thumb is also lost when there is a radial nerve injury. Now let's look at this. What these examiners will do. Now they will take all these different information, they will collect them together, and they will make a one single question out of it. We know that injury to median nerve, there is loss of opposition. Injury to ulnar nerve, there is loss of adduction. Injury to radial nerve will be the loss of extension in thumb. And that's why they also asked this question once, that movement of which digit can test all the long nerves of the upper limb. The all long nerves of upper limb, that is radial nerve, ulnar nerve and median nerve, they are all long nerves, and all the nerve can be tested by the movement of thumb. We do the extension, what nerve is tested? Radial nerve. You do the adduction, what nerve is tested? That is ulnar nerve. And you do the opposition, which nerve is tested? That is median nerve. So see, a simple piece of information, and from which it's a very important question which came out of it, and I'm sure none of us read anything like that in first year, that which movement of which finger or digit can test all the nerves of the upper limb. So that is one simple example of how the muscle has to be done. It's not about learning all the origins and insertion of the muscle, and that's what we're going to do for you. Let me take one more example here, and that example I'll take on the radial nerve. Now we all, as we know that we read anatomy in first year and then we read the ortho in the final year, and by the time from the first year to final year we reach, then there is a lot of gap in between, and we are not able to correlate all those anatomical features when we talk about the clinical injuries. We read a lot in radial nerve, guys. I mean, radial nerve starts in axilla, then radial nerve goes in the arm, in the spiral groove, then it comes in front of lateral epicondyle, then the radial nerve supplies the muscles of the back of the forearm. But when we read all these things in first year, we have to write a long question, and that's to write a long question we need to know the course and relations and all the branches and everything. But here, as we said, we just need to take the important and the necessary information out of it. So I'm going to discuss the radial nerve with you in such a way that the radial nerve is complete, and still we are able to do almost all the questions which are asked from the radial nerve without doing much here. So there we go. Now let's say we're talking about radial nerve, guys, and also do the differential for the radial nerve. Now let's say this is the humerus here, and there is a spiral groove which is present in the humerus. I'm sure you all know about spiral groove or radial groove. Now radial nerve begins in the axilla. Now let's say from here, from the axilla, the radial nerve from the axilla, it goes into the spiral groove, and then it comes in front of the lateral epicondyle. This is lateral epicondyle. It comes in front of the lateral epicondyle, where it divides into a superficial branch and a deep branch called as posterior interosseous nerve. This here is a superficial branch, and this nerve that you're seeing here, this passes between the two heads of supinator muscle. Cubital fossa is having a supinator muscle in the floor, so the nerve passes between the two lamina of the supinator, and then it runs at the back of the forearm, and this nerve is called as posterior interosseous nerve. This is supinator muscle here, and that is posterior interosseous nerve. Now if I say that this much of radial nerve is good enough to do all the questions, you probably will not believe me. But guys, radial nerve going in the axilla, radial nerve present in the spiral groove of humerus, radial nerve coming in front of lateral epicondyle, and then dividing into two branches. If you know this part of the radial nerve, trust me, half of the job is done here only. Now what we need to know out of this is that what muscles are supplied by radial nerve at different level. Now radial nerve in the axilla, it supplies triceps muscle. Which head of triceps? Don't bother. because even if there is an injury to long head or medial head or lateral head, actually there is a loss of extension movement. So why to bother about heads? So just triceps is supplied in the axilla. Then it again supplies triceps in the spiral groove. So tricep is supplied in the axilla and then it is again supplied in the spiral groove. Then when the nerve comes out from the spiral groove, it supplies two muscles before lateral epicondyle. One of the muscle is brachioradialis. I'm just writing BR here. This is brachioradialis. And one very, very important muscle, that is ECRL, extensor carpi radialis longus. Now we may not have paid much attention to this muscle in our first year, but trust me, this is one muscle, guys, which will help you in the differential diagnosis for the radial nerve injury. ECRL, extensor carpi radialis longus. Extensor carpi, the muscle is attached to the carpal. It is one of the wrist extensor. Extensor carpi radialis longus. Then we got a superficial branch and we got a posterior introitious nerve. The superficial branch of radial nerve, it supplies the skin of lateral 3.5 of dorsum of hand. It supplies the skin of the lateral 3.5 of the dorsum of hand. That's what the cutaneous nerve and the superficial nerves are doing. They're supplying the skin. And then we got this posterior introitious nerve. Now posterior introitious nerve is supposed to go behind and supply the muscle in the back of forearm. And all the muscles supplied by the posterior introitious nerve, they are all extensor muscles. Why to remember their name? Just remember, all extensors of the forearm are supplied by radial nerve, including extensor digitorum. So it supplies all extensors along with one muscle which I need to mention here specially, that is extensor digitorum. Extensor digitorum. Now look at this, guys. ECRL, extensor carpi radialis longus, and extensor digitorum, which I have highlighted here. Trust me, radial nerve is done. This is all we need to know about radial nerve when it comes to the kind of question that we need to deal with. Radial nerve in the axilla, it supplies triceps. Radial nerve supplies the tricep muscle when it is in the spiral groove. Radial nerve supplies ECRL above the lateral epicondyle, and radial nerve supplies extensor digitorum, the muscle which is responsible for extension at metacarpophalangeal joint, that is extensor digitorum by posterior introitious nerve. This information is good enough, and based on this information I can do the clinical questions which are asked on the radial nerve. Let me show it to you. So there we go. Now that's again we have the same picture which we just discussed, that is there's a radial nerve and the branches of radial nerve. Now at certain points, these are the most common site of radial nerve injury, guys. I mean, this is A here, that is axilla. Radial nerve can be compressed in axilla, that is case A. Radial nerve can be compressed in the spiral groove, that is case B. Radial nerve can be injured in front of lateral epicondyle, that is case C, and there could be a direct trauma to the posterior introitious nerve, that is posterior introitious nerve. There could be direct trauma to posterior introitious nerve. Okay, case A. Now when we say case A, that is the nerve compressed in the axilla and we call it crutch paralysis. This is called as crutch paralysis. Now see what happens in crutch paralysis, guys. This is because we have a very limited information about radial nerve here, so it's very easy for us to look into the main features of that particular condition. If a nerve is compressed in axilla, that means that is crutch paralysis because of using abnormally long crutches. That can lead to the compression of radial nerve here in the proximal part, and all the muscle supplied by the radial nerve and everything else supplied by the radial nerve is gone. It's all involved in that case. So if the radial nerve is compressed in axilla, what will happen? Tricep muscle is involved. There is involvement of tricep muscle. So a person cannot do extension, so his elbow or his or her elbow will be in flexed position. So one thing in crutch paralysis will be flexed elbow. ECRL, all extensors, extensor digitorum, that means all the extensors supplied by radial nerve is gone, and we know when all extensors supplied by the radial nerve is gone, there is a wrist drop. We all read that radial nerve supplies extensor, so injury to radial nerve will lead to wrist drop. So there will be a wrist drop. and there is also something called as finger drop. Probably we don't read this thing in first year, that what is a finger drop. This is a wrist drop, guys, and this is a finger drop. That means injury to the extensor digitorum or the nerve supplying extensor digitorum muscle will lead to the finger drop. A person is not able to extend the fingers, so there is a wrist drop as well, and there is a finger drop as well. So we do have a finger drop also in this case. That is in case of crutch paralysis, case A. Let's differentiate case A from case B. Now what is case B? I'm sure you all know that when the nerve is compressed or injured in the spiral groove, we call it Saturday night palsy. So there is the Saturday night palsy. And what you see in Saturday night palsy, that when you look at when you talk about the differentials in here, we always need to look at what proximal muscle is saved. So injury is at B, that means all the muscles supplied below B are involved, but what is saved? Some head of triceps are saved, I mean some part of tricep is saved. So if a tricep is partly involved, will a person have a flexed elbow? No. There is weakness in elbow extension, but he will not come to you with flexed elbow here. So in this case there is weakness in elbow extension, and rest of the features are same. We still have the wrist drop because all the muscles are involved, and we still have the finger drop because extensor digitorum is involved. So there is a wrist drop here, and we still have finger drop. Wrist drop and finger drop. Case C, more you go down, the challenge will keep on increasing. Case C, guys, if the injury is in front of lateral epicondyle, that could be because of lateral epicondylar fracture. So let's say if there is a lateral epicondylar fracture. So in case of lateral epicondylar fracture, what differential you will see here? So if the injury is at C, this part is saved. So first of all, what muscle is completely saved? Triceps. Tricep is perfectly alright, so there is no issue with the elbow. So elbow extension is fine. And there is something else which is also saved, that is ECRL. And I told you that this muscle will help us in the differential, guys. Extensor carpi radialis longus is saved. One of the wrist extensor is still saved, it is spared. So will there be a wrist drop? No, because one muscle is saved here, so there will not be a wrist drop. But what muscle is still involved? Extensor digitorum is still involved in this case, so we only have a finger drop. So when there is no wrist drop but finger drop is present, then probably it is injury in front of lateral epicondyle. So guys, no wrist drop. No wrist drop. Why? As ECRL is spared, it is spared, but finger drops are still present. Finger drop is still present. And then finally we have this case D, when there is injury to the posterior interosseous nerve. Now how can we have injury to posterior interosseous nerve? The injury to the posterior interosseous nerve can be because of the fracture of the radial head. It can be because of the surgical excision of radial head. So whatever the reason may be, if there is injury to posterior interosseous nerve, if there is injury to posterior interosseous nerve, then look at it, what is saved again? All that is saved. Again, no issue with the elbow. Again, there is a wrist drop because which muscle is there is no wrist drop because which muscle is spared, there is ECRL, and we still have finger drop because extensor digitorum is involved. Then how will you differentiate C and D? And there comes the role of dermato. If the injury was at C, then we have these features, no wrist drop and finger drop, but cutaneous sensation is lost on dorsum of hand. But in case of posterior interosseous nerve, the injury is here at case D. That means we again have no wrist drop, we still have finger drop present, but the important point to remember is that there is no sensory loss at dorsum of hand, and that is how we differentiate the radial nerve injury. Injury in the axilla, there was a flexed elbow, there was a flexed wrist, you can say wrist drop, and there was a finger drop also. Injury at in the spiral groove, there is only wrist drop and finger drop present. Elbow was just weakened. Lateral epicondylar fracture or injury to this point C, in that case no wrist drop because ECRL is saved and finger drop is present. An injury to posterior interosseous nerve, that means there is no injury at C, so what nerve is also saved? That is superficial branch is saved. That is why there is no sensory loss on the dorsum of hand, and rest of the features are just like C only. So this is just one topic to tell you that how it is being done, because radial nerve is a big topic, and then we have to do the radial nerve injury. So collectively that's a huge topic that takes a lot of time to read. So I think this kind of radial nerve you can only do in matter of minutes only, and it's very easy to look into the differential features of the radial nerve injury. That's all from my side. Thank you so much. God bless.